Hello, Colin Hung here for Healthcare IT Today in the Vive conference in Nashville, Tennessee. And I am truly excited to sit down with my next guest. Adam Mariano is the President and General Manager of Healthcare at LexisNexis Risk Solutions. Adam has an incredible background. He is a nurse, a civil rights defense attorney. He was a semi-pro athlete, and he is a tireless, dedicated patient access and access to care advocate. I'm excited to sit down with him because, as we know, right now, there is a bit of a downturn, a bit of a lull, let's call it, in terms of DEI initiatives across the country. And unfortunately, patient access is being lumped in with those initiatives. I think these are two different things, and I want to ask Adam if that's a correct way to think about things. I also want to ask him what we can do to improve access and why it's so important to think about it even now. I can't wait for you to hear our conversation. Let's get to it. Adam, welcome to the program.
Thanks, Colin. Nice to be here.
For the benefit of our audience, can you just give us a quick introduction to who you are and your role at LexisNexis Risk Solutions?
Sure. I'm Adam Mariano. I'm the president and GM of LexisNexis Healthcare Division. We are a data and insights company focusing primarily on three things: provider insights, consumer insights, and then, as we like to talk about, market insights, essentially where healthcare happens. And so we're data, insights, and services in those spaces.
I'm excited to sit down with you today because you are a tireless, very dedicated advocate to patient access and to improving that for everyone.
Mm-hmm.
And, you know, I got to say, like right now, access is suffering maybe from a little bit of a lull, maybe a little bit of a trough, because it's being lumped in with DEI initiatives. And in my mind, the two aren't the same. Do you agree with that statement, first of all, that the two aren't the same thing?
They're not the same thing. And you could certainly have an access program be part of a DEI initiative. And I know there's a lot of friction right now around those initiatives in the space, but we've had access problems. We've had access problems in the US forever. And they're issues across the spectrum. So place of service. Is there a place for me to go get primary care or specialty care anywhere in a commutable distance to my front door? There's cost. There's time of day if you don't have sick time, or you can't leave the office during business hours. Are there night and weekend hours for you to go to a visit? But there's also all the thresholds of access because of barriers to care around your coverage, or the fact that that specialty just isn't managed in a location you live in, and the only place to go is to a large-scale health institution in a tertiary research center in New York City, for argument's sake, and you're in the middle of the country.
Mm-hmm.
Those initiatives have been a struggle all along, and they're the things that drive quality of care. They reduce the cost of care. If Colin can't go to a primary care visit and ends up in the ER and ultimately admitted to the hospital, you're talking a 10 or 100x cost in delivering care. And as we've seen the primary care market sort of dry up, you're watching community health systems struggling, tiny little margins. You're watching all the pharmacies bought up a bunch of primary care and then divested a bunch of primary care, and I think incidentally created new service deserts. You have lots of, I would say, ubiquitous now almost digital care coming into the ecosystem. So text-based health, telehealth, tight-knit small service vendors. You've got Amazon and others in the space. But that assumes you have access to broadband. It assumes you have access to a cell phone with a big data plan, or that you even know about it. Right? And so every one of those things is an access issue. All of them drive relative cost, quality, and delivery of care across the ecosystem, and quite frankly exist outside and before we started calling things DEI. These have always been issues for health systems.
Yeah, I like how you put that there, because even though I might have coverage, it doesn't mean I have access.
100%.
Right? And that you've even differentiated for me those two issues, because I may have something covered by my plan, but if I have to drive 100 miles to get to that specialty, or it's not even offered in my zone, I mean, what's the point, right? And
100%. Or a doctor doesn't have an appointment for 6 months. That's a coverage issue. right? And it's why the federal government was pushing so hard on directories for payers to say, hey, not only is there a provider in my space for the specialty, but also they're taking new patients. But that's always been sort of vagary. It's like, well, taking new patients when? Is it when I'm 57? Is it this week? Is it only on Tuesdays at 4? Right? All of those things are critical. But it's also that is the differentiation. Lots of people who have coverage don't have access. If you have a mobility problem and the only place you can go has stairs, or you can't get to it on your transit route, it doesn't exist for you. So you do have an issue there. And some of this is how do you really get a profile for a patient or a health plan member that speaks to access and the patterns. I like to call them commercial determinants. We talk about social determinants all the time, right? There's the 80% of your outcomes that are driven by things that are not diagnosis. And then there's your diagnosis. And then if you layer on top of those two things, if you happen to get lucky enough to know all that about a patient or a member, then it's, all right, from my front door, what are the realities about me getting from where I stand to that service endpoint or to a visit? And that's really the commercial determinants. It's like, that's the stuff we all deal with every day. If you live in the center of a city core and there's 4 offices you can walk to, or you live in a rural suburb and you have to take a bus to a bus to a bus or drive 200 miles, you don't have access.
I like how you position that in terms of the patient journey, if you will, to
Exactly.
get themselves to the facility for care or to the doc for care. You covered that last bit there where, hey, like you have the coverage, you know where you need to go, but now it's just a matter of how do you get there, and that's access. That's
Yeah.
access. So a lot of what we've talked about seems very infrastructure related. The number of docs, the place where they practice, those kinds of things. Those aren't easily solvable. So are there parts of access that are a little bit easier to address than those types of things?
Yeah, there are. I mean, it's going to be very hard to solve numeracy problems. We've had a nursing shortage and a primary care physician shortage. I'm a nurse, and I started as a nurse in 1994. And so I'm by no means a 150-year-old, the world's oldest man. I haven't been around since the beginning of medicine, but I've been around a really long time. And we've had nursing shortages on and off the entire time. We've had primary care shortages on and off the entire time. And right now we're sort of at a really low point in both of those things. And because we had a lot of facility closures, I mean, in my town alone, they shut down 2 or 3 ERs. There's not one near my house anymore. And one of the other local health systems just went bankrupt under VC. And so they're shutting the system down. The state's trying to fight them to keep it open because there are no facilities for people to go to. So that problem is a hard one to solve. And the only way we solve that really is start to make it easier to mint nurses and docs, which is think about insurance cost and us thinking about perhaps subsidizing some of the education and also doing a better job recruiting. But that being said, you're watching health systems now hire virtualists, which are folks licensed in other states so they can do telemedicine, because you can't get enough docs in, say, Delaware. So I'm going to go to Pennsylvania, Jersey, New York, Maryland, the surrounding states, and recruit docs to fill up the edges of their panel if they're not busy. And you're seeing the same thing in all the telehealth services. So you're going to have to bridge it with telehealth and virtual care. You're going to have to bridge it with home care and kinship care, which you're seeing a rise of, and a lot of reimbursable care in home. And I think you're going to see this sort of, and we talked about this in the panel yesterday, this like fragmented democratization of healthcare. And it's sort of like you're going to need a halo of multiple service entry points for people's comfort level and, quite frankly, what we can afford to give them. And we're going to struggle to pull everybody into a mix that they can adopt. And so this is when people fall through the holes, and why you need to think about how you monitor populations of patients for the things you can't see. And that's why we talk about social determinants a lot. And it's if you're my doc and you see me 3 times a year for a critical lung clinic visit, and somewhere in that 90 days in between, something happens. Like I lose my job, my mobility, I break my leg. I no longer have someone living with me. I have an issue with where I live. The transit route changes and there's no longer a bus on my corner. You won't know till I don't show up at that visit. And we talk to, tier 1 research systems and huge health plans, and they'll all tell you, if I can get a patient over the threshold into an office, I can help them. I can solve what their problem is, or I can at least treat them, and I can keep the cost down, and I can manage their access problems. Problem is, I never know why you don't show up until you're not there. And then even then, I might not know the reason that kept you from coming to that appointment. So those no-shows are probably one of the most expensive parts of our healthcare system. And so access is, how do I solve no-shows, and how do I get you to book the appointment in the first place, but how do I help you keep it? And that's the, how do we, you can think about a day like today. It's snowing here in Nashville. Everybody panicked and left early because it's a city that doesn't get a lot of snow, and climate is shifting a lot of things around. In places like Nashville now get snow somewhat regularly, but still don't have the equipment and the know how to deal with it. And you can imagine a day like today for a critical health appointment, trying to get around when buses are shut down. I mean, I waited for an Uber for 2 minutes yesterday. It was 14 minutes today because people can't drive. And so this is a perfect example of, this is a bad access day for patients. And so thinking about how we solve those logistics when we talk about patients, now that profile, which has always been important, is getting more complex as the landscape shifts for care delivery.
You introduced two terms there that I love: kinship care.
Yeah.
And you call it the democratization, fragmented democratization.
Yeah.
That, I love it. I
Yeah.
love it. So let me ask you this, Adam. When we properly address access, which I know is a challenge, but it sounds like there's multiple ways to approach the problem. When we solve it, what are the benefits? What are things that we're going to notice as either on the provider side or the patient side that all of a sudden become better?
Well, we're never going to solve it.
Okay.
I'm an optimist because I'm a civil rights attorney in my private life. I'm a pessimist because this is an organic problem. It's like, you can think of this as a continuous quality improvement problem.
Okay.
Right? There's always going to be a new generation of people. Cities change shape, transportation change shape, economy moves, administrations come and go, rules change. And so there's always going to be an access problem for somebody who's left out for some reason. Right? They're either, all the things we talked about, right?
Mm-hmm.
All those things change all the time. So as you improve it, though, you can guarantee that if you get patients to more preventative care visits, their overall cost of care goes down. So if you're somebody who worries about efficiency and cost, this is how you get there. You make sure that everybody has preventative care. There is not a single study that argues with that point. Like, this is like, people, donuts taste good, right? It's a thing we've solved. We don't need any more science around this. We've found that if you get people to preventative care, their overall cost of care, their outcomes, mortality, all the first two things go up. The second thing goes down, right? Patient satisfaction goes up. Their ability to comply with care and compliance goes up. But you also, just the length of episodes of care shrinks. So how long you're sick and the severity of that sickness goes down. So all of us benefit because taxes are less burdened. The health system is less burdened. Docs don't burn out. Nurses don't quit. Patients are compliant with care and have better quality of life. And quite frankly, they get back to work. So you don't impinge on the economy. All the bad things that happen, right? You start to shrink when you get people into preventative care. And it is probably the most ubiquitous and the cheapest thing that we can alter. And even if it's virtual visits, it's better than nothing. So I think that the thing that people have to think about is incremental change is still change. And we get caught up in this. You got to fix it all at once. You got to fix the entire problem. This is not going to happen. I had a wrestling coach once who told me, you eat an elephant a little bit at a time. I don't really want to eat elephants, but he's right. It would be a hard meal all at once. And so you start with a bit of the tail. But we know the critical places. We know where the rub points are. And I think, polluting that with, I'm going to argue over the name of things, is sort of silly. We have lots of access problems in our health systems. Everybody knows it. And regardless of the angle you come in, cost containment, quality, if you're looking at equitable care, it really doesn't matter. The problems are all the same. It really is the truth.
I love that. And I probably wouldn't have been able to tell that you were a civil rights attorney, by the way.
Yeah, I know. It doesn't show.
It doesn't come through at all.
Yeah.
Well, Adam, I've asked you a lot of questions about very broad industry. I want to get a little bit specific with you now. What are you working on at LexisNexis Risk Solutions that's got you excited?
Well, I mean, we work on, it's one of the joys. It's one of the reasons I took this job. So as a civil rights attorney, as a nurse, as a parent, as a young parent, I didn't have access. So it's this is lived experience for me. We every day get to help systems get better insights for providers and for patients, and to actually lower some of the barriers to care for folks and to pave some of the pathway for access. So for me, I'm really excited that we are constantly working on innovation in that space. So whether it's trying to drive social determinants data for folks, or providing insights into access patterns for providers, or really just helping systems optimize their patterns and stuff, we do it every day. It's the great thing about it is as the industry evolves, we move with them, and all of that is baked into a 40-year history of identity management. So we're helping folks figure out who they want to talk to from a care and treatment perspective, which providers they need to leverage to get things done, and ultimately how to make that system run better. And so it really is an opportunity for us to drive better care all the way around.
Is there any aspect of the solutions that you offer that is really hot right now, or that people are really kind of going, "Wow, I really need to invest in this"? Or...
I mean, social determinants never goes away. I think it's the conversation we're having is it's all about access and patient engagement or membership engagement, but also it goes back to how can I make sure I can get an appointment for you and get you over the threshold to treat you. And it's the same thing if you're thinking about clinical research. So we work in the life sciences space. It's just, how do I get patients into clinical research studies and make sure they can complete the trial? Same problem. And the other market we work in is pharmacy. We work with big box pharmacies and we work with chains. And they have the same issues. Now that you've watched this happen, almost nationally, all the large scale pharmacy chains closed a bunch of stores. And a lot of them invested in primary care and then divested themselves of primary care. And so we talk about this. There was a wave of new access, and then the ocean sort of went back out. And so now you have all these places which are service deserts. You have patients and consumers who had an analog relationship with somebody, got to walk into a counter, talk to a pharmacist, get something, and now they're gone, and they're moving back to mail order in a lot of cases. So you're going to have to now refit your whole population of analog people with a digital footprint. We support those kind of things, and so we can help with baselining that population, figuring out the best way to connect with people and contact them, and ultimately to figure out, are there obstacles to them getting to where you need them to go. But every time we do this, we have to take people we got people comfortable with a little bit of digital care during COVID. And we said, okay, well, everybody go to the place of service where you used to go. And we closed a bunch of them. And now you created an access problem. And so now you have to give that, we'll call it hybrid blended access to people, where you have a digital footprint and you have an analog footprint. And how do we help you knit those together to deliver care on both ends of that spectrum? So, we're excited about that. And I'm honestly excited anytime I can provide better healthcare for all. So anybody I can help get a doc, get care, and participate in clinical research, help their family. That's what it's all about at the end of the day.
So, well, let me go on that road for just a second with you. If I was a person listening, watching, listening to you, and I'm now excited to try and address access issues, to be a champion within my organization, what advice would you give me to kickstart that?
I talk to executives a lot, which is always interesting. So I get brought in for like quarterly business reviews, and I get brought in to talk strategic conversation with folks about how they're making large scale change in an industry. The problem is sitting in these chairs. So you and I sitting here in a very nice building in Nashville, a 3-day event inside a hermetically sealed place, sort of isolated from the rest of the world, you can get disconnected from what really happens on the ground. And so even somebody like we talked about with the best healthcare plan in the world, in a walkable environment, they can still not have a clear pathway to care. And I think it's get out of your office, get off of your office and desk chair, get away from your computer, and go out and see how people experience the system. And so whether you're a payer or a provider, or you're in pharmacy, or you're doing life science research and product development, is go out and experience what happens to people who participate in what you offer. And get connected, like get down in, don't be afraid to read the comments, right? It's terrible. I realize the internet can be a scary, scary place. But honestly, if you spend time, I still volunteer in clinics. I have a daughter who's in her 30s who is, the first generation of kids to really not remember the world without an internet. Like I do, but she does not. And she is digitally focused in things, but she still will tell you about what's good and what's bad in this ecosystem. I use her as a test bed a lot of the time. We have lots of conversation about pragmatism, right? And we live across a state line from each other about 30 minutes apart. And the realities are very different on both sides. She lives in a more rural space. I live in a more urban space. And so there's a different conversation going on there. But for me, it's about, I don't ever really want to lose touch with what it's like to be a nurse. I don't really want to ever lose touch with how civil rights tides move in the country. But I also don't want to lose touch with the struggle of the people we serve and how they struggle on a day-to-day basis. What's a doctor and nurse experience right now in downtown Philly? I can tell you. I mean, I make sure I stay connected to it. And so I think the number one thing I would say to other executives is get engaged at a street level. Walk in a store. Like, don't walk in a store with an entourage. Walk in a store in your t-shirt and jeans and go walk around, try to buy something. Try to get a script filled. Try to get a visit. Right? Don't go the easy path. Go an uncomfortable route you've never been to. Go to a facility you've never been to and figure it out. And I think it's really eye-opening when you stand in other people's shoes, which we should all do. I think this is just, you know, it's a thing you were probably taught too. I was taught this as a kid, was always try to stand in somebody else's shoes. Really, even from a business perspective, it's an excellent thing because you always get insights about an assumption you made, about a thought process that you've been carrying around for 10 years, and it's often wrong. But if nothing else, even if you were right, you're going to get some insights you didn't have the day before.
Well, Adam, we could talk for hours. I
Yes.
love this conversation. Unfortunately, we have to end it, but let me ask you this final question.
Okay.
Where can people go to learn more about LexisNexis Risk Solutions?
Risk.lexisnexis.com. And I can tell you, I have to think about that URL every time. And I'll make all my marketing people mad. But if you search LexisNexis, if you search LexisNexis Healthcare, if you search Risk Solutions, but risk.lexisnexis.com, and then you can go to healthcare underneath that.
Awesome. Well, Adam, thank you so much for being on the program today. I totally enjoyed this conversation.
Thank you, sir. It's good to see you.
Hey, I really, truly want to thank Adam for sitting down with me today. It was wonderful to have that conversation with him. There was just so much to unpack there. I loved his comment about the fact that you shouldn't be afraid to read the comments online and that you should go out and step into the shoes of the people you're trying to serve and the people you're trying to help. You'll uncover insights, you'll gain a tremendous new perspective that will help you improve some of the things that we can improve in terms of access. Yes, he mentioned a lot of infrastructure and very big picture issues of solving the numeracy problems he talked about in terms of the number of nurses and docs available. We can't all solve that, but we can solve making filling a script a little bit easier, finding a doctor a little bit easier. And that's the positive piece that I'm taking away from this conversation with Adam. Well, I hope you enjoyed this interview. If you did, please mash that like button and click subscribe. Also, head over to healthcareittoday.com where you can find more great content like this. I'm Colin Hung for Healthcare IT Today. Thanks for watching this video, and I'll catch you on the next one.